Hola. Thank you. I'd like to thank the organizers for having me over here in Valencia. Mila, Julio. I'm going to kind of shift gear a little bit and talk about big data, which you've been hearing a lot of in the last few years. And over the next 15 to 20 minutes, I wanted to paint the landscape, the problems that we have in the way we deliver healthcare, and we're getting numb about hearing how inefficient the system is, how poor the outcomes are despite the money that we're pouring into healthcare. So we often hear that the healthcare system is broken, the practice of medicine is broken, and this is very disconcerting, especially for the young doctors, young nurses, young pharmacists who are getting into the field. And then I'm gonna describe the potential of how big data could potentially transform the way we deliver care. And finally, I'm gonna touch on some of the challenges that we face in terms of allowing data to drive the way we practice medicine. I'm going to start off with a quote from Don Berwick. Don Berwick is the founder of the Institute of Healthcare Improvement and also was the ex-director of Medicare and Medicaid. And he says that every system is perfectly designed to achieve the results that it gets. So the number of medical errors that we see when you get admitted to the hospital, the number of hospital-acquired infections that a patient gets, that's all part and parcel of how we design the way that we deliver care. And I always start off with this report that was published last year by the Institute of Medicine. And Institute of Medicine is one of the most respected institutions in the United States in healthcare. And they looked at data coming from 2005. And they, after analyzing that data, they found that about $750 billion were wasted on that year in healthcare expenditures. That means about 30 cents for every dollar spent in healthcare was completely gone into waste. A large fraction of that waste was in the unnecessary services. So these are cardiac catheterizations that weren't needed in the first place, pacemakers, hip replacement, knee replacement. But on top of that, we think that it's actually an underestimation, the amount of money that we waste in healthcare. And according to the Institute of Medicine, one of the biggest contributors to waste in healthcare is the fact that in our daily practice, only 10 to 20% of the decisions that we make are actually based on evidence. A lot of the recommendations that we get are still based on expert opinions. They're based primarily on prospective randomized controlled trials, which are the gold standard, where we blindly randomize a group of patients to treatment A and another group of patients to treatment B, and then we compare the outcomes of the two. And with that, we're guaranteed that there is a balancing of confounders or variables that might affect the outcome. But it's not as simple as that. It's very difficult to apply that to the patient in front of you. Most of the time, the answers that we get are not black or white. It's not like everyone who got treatment A got better and everyone who got treatment B got worse. Most of the time, you get one number that is population-based. There is an 8% reduction in complication rate. And it's very difficult to translate that number when you have a patient in front of you. Is my patient going to be part of that 8% who would benefit from this treatment? Or is he or she going to be part of the 2% who developed a bleeding in the brain as a result of the complication? And it's really up to the clinicians to apply the findings from that study on his or her practice. There have been a lot of criticisms with the way we derive evidence in medicine. One of the landmark studies was published in JAMA in 2005. And John Unitas is one of the leading critics of the medical research establishment. And in this particular paper, he looked at the most cited papers from the previous century. And there were 49 of them that he looked at. 45 were repeated. No, 45 actually found an effective treatment. In 34 of the 45, they were repeated subsequently. And in the repeat experiments, they found that there were more that actually found opposite results. So they completely pulled back the findings from the previous trial. Or they found that the benefits that the original trial reported was highly exaggerated. So we have this what we call medical pendulum. It's swinging back and forth. One decade, we think that steroids are good for a severe infection. The next decade, they tell us that no, steroids are not good and could be harmful when you have a severe infection. And it's all about how you analyze all the data coming from the trials. More recently, this paper got published this past summer in the Mayo Clinic proceedings. And they looked at just one journal, the New England Journal of Medicine, which is the dream of every clinician, really, in terms of publication. It's got the highest standard for peer review. And what they looked at were some trials looking at standard of care. Is the standard of care really the best treatment that we could offer? Is that the best practice? And they looked at 363 articles. And interestingly, there were more trials that found that the standard of care was not the best practice and led to a reversal in the recommendation. There was an accompanying editorial that was written by John Unides, who wrote the JAMA paper that I showed you earlier. And he entitled this editorial, "How Many Contemporary Medical Practices Are Worse Than Doing Nothing or Doing Less?" And in that editorial, he said that half of what we know might be wrong and the other half useless. Again, this is very disturbing for doctors like me. Everything we've learned in medical school could be wrong. I remember one of the deans that welcomed the students said that, "I'm going to warn you that probably 50% of what you're going to learn in the next 4 years could be wrong." Unfortunately, we don't know which 50% is wrong. And John Unides is also the author of the most downloaded article from PLOS called "Why Most Published Research Findings Are False." Who is to blame? Previously, we had blamed industry. We had blamed the pharmaceutical companies. We had blamed the makers of medical devices as having too much input in what gets published. But more and more, everyone is now stepping up that we are all part of the problem. This is from a meeting of medical researchers in Chicago this past September. And reading the second paragraph there, conference sessions highlighted the journals not correcting their known errors, researchers not sharing or archiving their data, and universities not guarding against sham medical trials. And to repeat that quote again from the keynote speaker of that conference, Kay Dickerson, she said, "We're all in the ecosystem, and it's broken everywhere." More recently, this got featured in The Economist just a few weeks ago, how science goes wrong. And it tells you that it's not limited to medicine. The problem exists in all the other domains of science, that there's a push for publishing more than really finding the truth or learning what's effective in medicine. They've used the term careerism, where it's all about publications and getting promoted rather than finding out what the answers are to the questions that we have in medicine. And they're saying that it's less likely if you have a negative finding that you are going to submit that to a journal. And it's even less likely that a journal is going to publish something that has negative results. And they explained nicely why a negative result is actually more likely to be true than a positive result, because of the way we design studies. In the intensive care unit where I work, we do a lot of monitoring. We measure minute to minute the blood pressure, the respiratory rate, the saturation of the blood. And this is a paper that looked at what types of monitoring has been shown to improve outcomes in the acutely ill patients, written by one of the big names in ICU, Jean-Louis Vincent. And in that paper, they concluded that there is no broad evidence that any form of monitoring improves outcomes in the ICU, and most commonly used devices have not been evaluated by randomized controlled trial. So what I'm trying to say is that the current paradigm in generating best practice is not adequate. We need to somehow change our approach. We can't rely on just prospective randomized controlled trials. I'm not saying that they're bad, but definitely they're not enough to be able to find out which treatment is going to be benefiting which particular patient and in what particular clinical context. The practice of medicine needs a radical transformation. And we've heard about the big data. as late as the turn of the century, less than 1/4 of the data of the stored information that we have is digital. But at this point, less than 2% of all stored information is non-digital. Everything is now accessible and could be analyzed because they have been stored electronically. And that's true for medicine. For hundreds of years, we've wasted a lot of information. They're all in the paper charts that are stored in the medical records department, and they're just sitting there, and no one is analyzing these day-to-day experiments that we're performing on our patients. And in April of this year, the Institute of Medicine again made the case for analyzing that data that we continuously collect from our patients in the process of care. So they made the case for continuously learning from routinely collected data. And you're going to hear more and more about the phrase evidence-generating medicine. So it's no longer evidence-based medicine. The practice of medicine is, on a regular basis, generating evidence as well. In the United States, a lot of money is being invested in big data. So the National Institute of Health this past summer committed $24 million annually in the creation of big data centers of excellence. So in the last 10 years, I've been working in a lab at MIT called the Lab of Computational Physiology. And what we've done is we've been collecting all the data that is being obtained from patients admitted to all the intensive care units in a hospital in Boston called Beth Israel Deaconess Medical Center, which is where I work. And we bring them together. So they're coming from different systems. There are data coming from the laboratories. There's data coming from the hospital itself. And we've interfaced that with Social Security data. So we could actually tell if the patient is still alive now or if the patient died, at what point in time did the patient die. And we did something different. We made the data publicly available. We removed all the protected health information, all the proper names, all the dates, and we gave it away to the world. Obviously, there are data user agreements that people who want access would need to sign, and they would have to tell us what they intend to use the data for. But anyone can access the data, could ask questions, and what I have been doing in the lab is bringing together the data scientists and the clinicians, and together they interrogate the database to obtain the answers to questions that we routinely encounter in day-to-day practice. And we've talked about our experience in this data-driven learning care system in an editorial in the American Journal of Respiratory and Critical Care Medicine. So what are some of the examples, or what are some of the main themes that we use big data for? Number one is interrogating practice variation, which we like. When there's a lot of variation in the way the patients are being treated, it means that there's no documented best practice yet. So we looked at this, and obviously it's not as straightforward as it sounds, but we try to generate the evidence that would guide the clinicians who might face the same problem in the future. We come up with personalized recommendations, and you've been hearing that word over and over during this session. We're trying to come up with a calculator of the risk and benefit for every test and intervention. Are you going to benefit from an MRI in the middle of the night in the ICU? Will it give you an information gain that is worth the risk of traveling when you're very sick in the middle of the night? We're using the data to discover new knowledge and understand disease processes. A lot of the concepts that we've embraced in the ICU were based on animal studies from back in the 30s with 30 sheep or 10 dogs. And we think that the same concepts apply to critically ill patients because no one's ever experimented on critically ill patients. But we do that all the time in the intensive care unit. For the most part, we're experimenting because we don't know what really works best for every specific patient demographic, for every clinical context. And it's now time for us to analyze those experiments. So medical records are nothing but lab tests, lab notebooks. And we have to analyze them and extract information, extract knowledge from all those experimentations. And finally, we do a lot of predictive modeling, but not just predictive modeling of anything. I always stop the engineers when they try to say that, oh, I could predict this and predict that. And I always say, no, you start with the clinical need. As Martha said earlier, you start with the questions. You have to predict something that we could act upon, because even if you could predict something and there's nothing that you could recommend to clinicians of what to do to avoid that, then it's not going to be very helpful for clinicians. These are some of the steps in clinical data mining. Basically, we bring the data scientists, the clinicians, the epidemiologists, and biostatisticians together to really define the problem. And then we design the study together. We identify what patient subset to analyze, what exposure of interest we would like to analyze, what are all the confounding variables that need to be included in the modeling, as well as the outcome of interest. And then there's a lot of pre-processing that is involved because we're working with real data. So you're going to be capturing a lot of artifacts. The good news is that if you have 2 million data points, even a 10% noise level would not be that bad compared to the times when we have 100 patients in each arm in a trial. And there's a lot of going back and forth between the data scientists and the clinicians. Are we happy with the model? Do we think that this model is really representing what's happening in the real world? Or are there other hidden variables that could be explaining what the outcomes? And finally, the last step is bringing it back to the clinicians. Let's come up with decision support tools that the clinicians could use at the point of care so that it's easier for them to make those decisions in practice. So the vision is that when you go to a doctor, the treatment that will be offered to you is not based on what that doctor knows or what that doctor heard a week ago in a conference or what that doctor recollects from his patient experience, but the treatment recommendation is based on thousands or even 10,000 doctors who have taken care of patients who are very similar to you in terms of the variables that are important to the outcome that you're most interested in. A good example is cancer. What do you think is the contribution of chemotherapy in terms of a 5-year cancer-free rate? A study has shown that as little as 2 to 3% of chemotherapy actually contribute to a 5-year cancer-free rate. And they say that only anywhere between 25 to 50% of chemotherapy is adding value to the patient with cancer. That means that in the rest of the time, chemotherapy is only contributing to a miserable life of having nausea and vomiting and losing your hair without any prolongation of lifespan, without any improvement in your symptoms. So the key really is we have to identify which patient is going to be responding to a chemotherapy. And there are some advances in genomics. There are some lung cancers, for example, where we look for a certain biomarker and we could tell whether they're more likely to respond to a chemotherapy. But it's not enough. We can't wait for genomics to completely give us all the biomarkers that we need for cancer. But we have a whole wealth of what we call phenomics. Phenomics is the data that is stored in our electronic medical records. And maybe we could look for patterns whether if they have pattern A, B, and C, they're more likely to respond to chemotherapy X versus Y. And they've done that in this particular study where they not only looked at the literature in terms of predicting whether a woman is going to benefit from adjuvant tamoxifen therapy after being diagnosed with breast cancer. They also looked at a large database and looked at what features are more likely associated with response to tamoxifen. The biggest problem is what we call residual confounding. This is really the biggest challenge in big data. And this is making sure that the findings that you're seeing is based on the treatment and not something inherent to the patient or not something inherent to the clinical context. And some more challenges. The methods are not ripe. We've never had data this granular before. Also, there are no policies around data ownership and data sharing. We still don't know who should own the data that we're collecting from the patients. Majority of the clinicians are not aware of the problem, and there's not enough incentives to fix the problems. And one of the biggest challenges are the doctors. Doctors are very arrogant. It's not easy to convince us to change the way we deliver care. And let me just quote Rabbi Samuel Edels from the 17th century. The life of the patient and the soul of the physician are always at risk. And finally, just to advertise, we're having a big data in medicine conference at MIT this coming January. It's free for anyone coming from an academic institution. We will have hands-on data mining workshop. And in this workshop, we're going to be bringing together the data scientists as well as the clinicians together. And there's also an opportunity to participate remotely via a streaming of the conference or via WebEx with the workshop. Thank you.
Muchas gracias, Leo. Tres excelentes presentaciones, tenemos poco tiempo, pero creo que la última presentación de Leo nos engancha de nuevo con Ana para que nos cuente cómo la bioinformática afecta su trabajo y tiene un potencial para, junto con los grandes datos de la clínica, poder hacer realmente la medicina personalizada.
Bueno, la bioinformática es clave, es necesaria. Es decir, no se pueden analizar genomas sin bioinformática. Entonces, es una herramienta de trabajo fundamental. Pero bueno, eso es algo que hemos estado haciendo durante mucho tiempo. Ahora el reto no es tanto utilizar la bioinformática para analizar 1 o 2 genomas, sino precisamente desarrollar la infraestructura que te permite utilizar, digamos, ese Big Data o la información sobre los genomas de mucha gente de manera, digamos, simultánea o de manera dinámica para poder llegar a conclusiones sobre el tratamiento de un individuo, digamos. Y yo creo que el reto es tanto desde el punto de vista del análisis, como mencionaba anteriormente, es decir, los análisis bioinformáticos, pero también todo lo que es el manejo de la información, el transporte de la información, que a lo mejor a veces nos olvidamos un poquito de eso, ¿no? Y al final hacérsela presente al clínico, al médico, de una manera útil, que se pueda servir para tomar una decisión en aquel momento, ¿no? Y bueno, es un desarrollo paralelo, es decir, toda la parte de infraestructura computacional con el análisis y con el conocimiento de cómo funcionan los genomas van a la par, en la misma dirección.
Muchas gracias, Ana. A continuación, Martha, la pregunta es, ¿el diseño de EmVision al final permite abordar grandes problemas y atacar la complejidad hasta hacer más simple la solución a necesidades no cubiertas? Y eso se hace de una manera multidisciplinar y en un orden inverso al modelo de investigación y de innovación que tradicionalmente se ha llevado a cabo en los centros académicos. ¿Qué es o cuál es la particularidad más importante que ella ve o que hay que resaltar en la manera en que los fellows de EmVision abordan la innovación?
That's an interesting question. You know, I think we have to have faith in our next generation to be the, people that advance our knowledge. And in order for them to do that, the sooner they start taking responsibility and figuring out how to identify important problems to solve and developing the teams and the expertise required to solve it, the better off we're going to be. And I think, can EmVision take on the big problems? We're very young. You can't solve big problems in a year or 2 years. That's an incredibly short time. It takes decades. So I think the real message is it's a systemic change. I mean, Leo talked about the focus on publication. One of the first things some of those people on that video said was, I'm not getting any publications. Why am I thinking like this? I'm never going to get my next job. And I think just the fact that within a month of starting, having the opportunity where they could study anything they want on any problem as long as they could defend it, it helps you appreciate how radical that is. So that, from an academic standpoint, you can see how this happens. But from an investment in science and technology standpoint, for society, that's exactly the opposite of what you want to focus on. You want to focus on these big problems. So I think the other thing I should say is when you give people the opportunity to take on problems like this, they get infected with it and they think differently, whether they're the people actually doing it or the people helping to nurture and support this process. So I now firmly believe it's possible to, at least in pockets, change that culture.
Muchas gracias, Martha. Y hablando de thinking differently, Leo es uno de los mayores luchadores por un abordaje transformador de cómo los clínicos realizamos nuestro análisis, nuestra investigación de los resultados, cómo compartirlos y cómo ejecutar nuevas formas de asistencia sanitaria que sean más reproducibles, más personales. ¿Cuáles son las barreras más importantes que te encuentras cuando intentas encontrar colaboraciones o conseguir financiación para avanzar en la explotación de la Big Data con objetivos clínicos?
So status quo is always hard to change. I remember giving this talk at the NIH, am I on record here, a month ago, and I didn't realize that they take it personally when I start saying that the system is broken, because they built the system. And they take offense every time they hear those words that the healthcare system is broken, the medical research establishment is broken. So I have to be very careful now that those are not my opinion. I'm just quoting a lot of the articles that I'm reading. But status quo, according to Machiavelli, is one of the most difficult things to change, because the old school people have really benefited from the system, the way the system has been run, and you have very few allies for the people who might actually have some value from implementing the change. We're hoping that as the younger generation are more data savvy, they're really surrounded by data from Facebook and Twitter, then they're more likely to be open to allowing data to drive the way they practice medicine. But in my previous presentations, there always would be naysayers saying that big data is just going to give you big headaches, that there's no way you'll be able to flesh out the answers to the questions that you have, because there are just so many layers of complexities. And we realize that problem, and that's why we're working hand in hand with the biostatisticians to come up with new methodologies to really address the issues of residual confounding, really address some of the problems of causal inference.
Muchas gracias, Leo. Aquí tienen a 3 personas que están intentando, desde diferentes campos, cambiar el status quo. Esto es EmTech España. Enseñen a sus hijos código, porque probablemente sea el futuro de nuestro conocimiento. Muchas gracias.